Hello everybody, welcome back to the channel. Recently there's been growing debate on YouTube about whether to aspirate, pulling back on the syringe before injecting the COVID-19 vaccine. It seems to be mostly spurred by a popular YouTube influencer, Dr. John Campbell, who's a retired nurse with a PhD in nurse education. He seems to produce one, two, three, four, five, at least five videos on this topic by now. Let me know if I've missed any, and is prompting curiosity, concern, and even fear from friends, patients, and you viewers. I've already touched briefly on this topic during my last video, you can check it out here, and I still stand by what I said. Let's quickly watch the clip from my last video. Now, some influencers have questioned whether we should be aspirating the needle before we inject the vaccine into the muscle. You can see that when I got vaccinated, the nurse who did my vaccination did not aspirate. Aspiration is usually done to make sure that the injected substance doesn't go into any of the big blood vessels, which could cause a problem. The deltoid muscle, though, you can Google any picture of shoulder anatomy, and you can see that there's not really any big blood vessels around where the deltoid muscles are. It's basically just skin, muscle, and bone. So I'm okay with a nurse not aspirating prior to injecting me with the vaccine. So in this video, let me explain in detail why I stand by what I said. Again, this is not medical advice. For medical advice, please speak with your own physician or healthcare provider. So you may be asking, who am I to peer review Dr. John Campbell? Well, I'm a practicing physician in Canada who's given plenty of vaccines, including the COVID-19 vaccine. But I really don't care if you don't know who I am. I'm just trying to get the word out that not aspirating is not a cause for panic. And fear of not aspirating should not deter you from getting the COVID-19 vaccine. So my ask of you in this video is simple: to consider the strength of my arguments and weigh them against the arguments of aspiration advocates and make a decision for yourself. Know that I have nothing against the man, Dr. John Campbell. I think he's well-intentioned and his heart's in the right place. In this video, I'm simply presenting a counter-argument based on science, because the best decisions are always made after considering multiple perspectives, not just one. Let me also say that I could be wrong. I'm human just like all of you. So if I am presented with facts and proof that aspiration is 100% necessary prior to vaccine injection, then I will happily change my mind. So don't take my word for it, decide for yourself, but do so at least having considered both sides of the coin. Let's get started. The first reason I'll give you for not aspirating is that the aspiration videos that Dr. John Campbell has produced contain misinformation, some of which are easier to spot than others. I'll give you two examples here: cherry-picking experts and oversimplified explanations. Cherry-picking is easier to see, and here's a classic example. In this video, John Campbell has invited an expert from Denmark to join his channel and discuss the benefits of aspiration prior to vaccine injection. Now, I'm not questioning the credibility of the expert in question, but I am wondering, where are all the other experts on the other side of the debate? What about experts who disagree with aspiration, such as those from the World Health Organization? Where are they? Where is the other side of the story? So that's what we mean when we say cherry-picking of experts is a sign of misinformation. Other misinformation, such as oversimplification of explanations, is a bit harder to spot, because often you need a medical background in order to detect it. Here's one example. In many of John Campbell's aspiration before injection videos, such as this one or this one, he spends most of the time talking about the possible ways by which the AstraZeneca vaccine can trigger blood clots by just being present in the bloodstream. He doesn't specifically explain how directly injecting the vaccine into the bloodstream can cause blood clots. There is a subtle but important difference there. His argument seems to rest on the premise that the vaccine shouldn't enter the bloodstream. He even stated this at 1 minute and 13 seconds of this video.
Here we have the graphic. The jab is delivered into the muscle of the arm, but can sometimes enter the bloodstream. Well, yes, it can, but it's really quite simple that it shouldn't enter the bloodstream.
This explanation is an oversimplification. We know that parts of the vaccine can actually enter the blood once the vaccine is injected. This is because the deltoid muscle, like any muscle, is well supplied with blood. But normally the vaccine components do so over hours or even a couple days after vaccine injection. The presence of vaccine components in the blood is normal, is expected, and it should happen. That's how the vaccine works. The vaccine components in the blood attract immune cells to the site of the immunization, and that's how the immune system is activated and remembers the antigen or the foreign substance to be protected against. The issue with intravenous injection, or directly injecting a drug into the vein or blood vessel, is much more complicated than just the mere presence of the drug in the bloodstream. The issue has to do with the speed at which the drug gets into the bloodstream and how much of it gets in over that time period. You can see that for both the inadvertent injection of vaccine into a blood vessel and what typically happens, which is injecting the vaccine correctly into the muscle, they both result in vaccine components getting into the blood. Intravenous injection is not the only way by which vaccine components enter the blood. So, if rare instances of blood clots from the Oxford AstraZeneca vaccine is caused by the presence of vaccine components binding to platelet factor 4 in the bloodstream, it would be reasonable to suggest that the typical injection of vaccine into muscle could also cause blood clots, with or without direct injection of the vaccine into a blood vessel. This renders moot the directive for aspiration prior to injection. To imply that it's dangerous for any vaccine components to simply be in the bloodstream because of the lack of aspiration is not only an oversimplification, it's just wrong. So that's the first reason for not aspirating. Lots of misinformation underlie the rationale for aspiration. Similarly, the second reason for not aspirating is that the risk of vaccination without aspiration was exaggerated based on a single flawed study done in mice rather than in humans. In this video, John Campbell insinuates that the cause for myocarditis is intravenous injection of the mRNA vaccine directly into the veins, and he bases this conclusion solely on one study in a mouse model. What's the problem with this approach? I'll let John Campbell explain himself.
Now, this study is done in mice. Now, to be fair, okay, mice aren't ideal.
That's right, John. You can't just take an observation of something that happens in a mouse and say that the same thing happens in humans. Just as one specific example, a type of diabetes medication was found to cause thyroid cancer in mice and rats. But it's still on the market, it's still helping many people with diabetes today. There are also many reasons this study is flawed, which Campbell didn't touch on. Let's show one quick example, looking at the methodology of the study. So in that study, they used a weight-based dosing regimen of Pfizer mRNA vaccine. They used an average of 5 micrograms in mice versus the typical dose of 30 micrograms for human beings. Now, because it's a weight-based dosing, let's compare the weight of a mouse versus the weight of a human. The average mouse weight, and you can confirm this by just Googling average mouse weight yourself, is 20 grams, as in 0.02 kilograms. The average human weight is 60 kilograms, and again, you can confirm this by Googling average human weight. The ratio of mouse weight to human weight is actually 1 to 3,000. Humans outweigh mice by 3,000 times. So, if the dose of vaccine in humans is 30 micrograms, the corresponding weight-based mouse dose should have been 30 divided by 3,000, equaling 0.01 micrograms. However, the authors noted that they gave each mouse 5 micrograms. Compared with 0.01 micrograms, that represents a 500 times overdose in the amount of the Pfizer mRNA vaccine given to each mouse. Whenever humans take anything in overdose of 500 times the normal dose, bad things are bound to happen. It's not surprising the mice were harmed by the overdose in this study. Just another reason why the findings of the study isn't generalizable for the vaccination in humans. Now, this is why we don't make medical decisions from mouse models, because they can be wrong. We need to repeat the same experiments in humans before we can conclude that anything seen in mice is relevant for humans. The other concerning thing with this study is that they directly injected the mRNA vaccine into the vein of the mice. Back to what we talked about regarding how fast and how much of the vaccine gets into the blood, direct IV administration of any drug gets the drug into the blood very quickly. That is just not something that is possible upon vaccination, even if upon vaccination the needle hits a small vein or small blood vessel in the deltoid muscle. It's an unrealistic and inaccurate comparison between apples and oranges. We don't actually know what causes myocarditis after vaccination. For anyone to say or even allude that myocarditis after vaccination is directly caused by the lack of aspiration is actually, unintentionally or not, spreading information that may not be valid. In other words, it's misinformation. Now, only after someone who self-identifies as mom calls him out on it in this video does Dr. John Campbell clarify his position and say that aspiration may be one of several factors behind the cause of myocarditis. Mom correctly pointed out here that inadvertent IV injection of the vaccine cannot be the only cause of myocarditis, because if that was the only cause, then myocarditis rates would be seen equally across all demographics, not just in young men. I guess that's why they say mothers always know best. And indeed, nobody knows why myocarditis after vaccines tends to happen more commonly in younger men. But if there are lots of other factors involved, then why isn't Dr. John Campbell investigating all these other factors, all the potential factors that could be involved? Why make 5 YouTube videos all about this one topic of promoting aspiration? So that's the second reason for not aspirating. The risk of vaccination without aspiration was exaggerated based on a single flawed study done in mice rather than in humans. The third reason for not panicking about aspiration before injection is that even if the direct injection of the vaccine into a small blood vessel in the muscle is one cause of myocarditis, the risk-benefit trade-off is still in favor of getting vaccinated and getting vaccinated without aspirating. You should note that nothing in medicine, or indeed in life, is without risk. We take calculated risks, whether they're conscious calculations or subconscious calculations, every day in our own life choices. Medicine is no different. First of all, we already know that the deltoid muscle has no major blood vessels. This is actually confirmed by one of John Campbell's commentators, a self-proclaimed reconstructive surgeon, who confirmed this via a comment on one of Campbell's videos. I'll show this comment now, and you can pause the video to read his comment fully. So just how rare is myocarditis following COVID-19 vaccination? Well, let's turn to the data. The Government of Canada keeps very accurate and very up-to-date data about all COVID-19 vaccinations and adverse events. You can see that up to and including December 10th, 2021, there were 1,463 reports of myocarditis or pericarditis after vaccination. And that's after the delivery of almost 63 million total doses of vaccines. That puts the risk of myocarditis or pericarditis after vaccination at a measly 0.002%. Comparing that to your risk from the other things in life, the risk of getting blood clots from the birth control pill is around 0.1%, 50 times greater than myocarditis from the vaccine. The risk of getting into a car accident on any given year in Canada is 0.3%, 150 times greater than getting myocarditis from the vaccine. The risk of dying from COVID-19 in Canada is 1.6%, and the risk of getting hospitalized from COVID is 7.1% in Canada. Taking together the numbers from death and hospitalization from COVID-19, that's over 4,000 times more frequent than myocarditis from the vaccine. Keep in mind too that part of the hospitalizations after COVID is because of myocarditis caused by the virus, not by the vaccine. I'm in no way minimizing the effect of myocarditis on patients who have unfortunately suffered from this vaccine side effect. I myself have a friend and a colleague who developed myocarditis following the vaccination. It's a horrible experience, but here's the thing. My colleague was effectively treated. My colleague was a physician who recognized the signs and symptoms of myocarditis and got help. Myocarditis is a treatable condition, unlike death from COVID-19. And even after the first dose caused myocarditis, my colleague actually went and got a second dose of the COVID-19 vaccine, because they knew that the benefits of COVID-19 vaccination outweighed the risks. We make cost-benefit analyses in everything we do in medicine. So just like how you estimate that benefit of taking the Advil for your headache is greater than the risk of that Advil causing severe gastric bleeding, even without aspiration, the benefit of vaccination in preventing COVID-19 infection far outweigh the possible risks of myocarditis. The fourth reason to not aspirate is because we have evidence from previous vaccinations that it's not necessary. This is why the World Health Organization does not make it standard of care to aspirate before vaccination. Let's search the peer-reviewed literature together, just so that I can show you how I'm not cherry-picking my sources of information. This is PubMed. PubMed is a search engine that sorts through only reliable, valid medical journals and publications, and filters out bogus or predatory journals that publish non-peer-reviewed work. Note that Google Scholar, while it's a more accessible search platform, doesn't have such filters for high quality and reliable information. For a full explanation of this, check out Dr. Greg Tucker Kellogg's video on how to identify misinformation. So I type in our desired keywords: aspiration, injection, and vaccination, and I hit search. And that brings up a lot of results, not that many. In order to sort through the most relevant, I'll hit review, and that will filter the results into the articles that are review papers, basically summarizing the findings of all the other studies looking into this subject. The most recent review paper is presumably the one that has summarized the most up-to-date information. Now let's just check to make sure we're not missing anything else. So this does not apply. This is a funny title, but it's in Spanish, and these are not that relevant. So we can click on this, and then we can get the full text. When I search, I also go into PubMed Central. So PubMed Central, PMC, is basically a database with a more extensive collection of articles than PubMed alone. I do this just to make sure I'm not missing anything. So I type in aspiration, injection, and vaccination, hit search, and actually out pops another review paper that I hadn't seen before in PubMed. Clicking on that, so we'll get the full text from that as well. So let's look at Sisson 2015 first, from the Journal of Clinical Nursing, entitled Aspirating During the Intramuscular Injection Procedure, a Systematic Literature Review. So first in the introduction, they define what aspiration is, and they say that it's standard teaching practice of trying to avoid blood vessels with intramuscular injections. In the background, they then state that the practice of aspirating to avoid injecting medicine into a blood vessel most likely stems from reports of intramuscular injections inadvertently given intravenously. And some of the earliest recorded accounts of such errors focus on complications where penicillin was given intraarterially. However, these reports mainly focus on injecting into the gluteal muscle, a practice which is no longer routinely recommended, so it seems like the standard teaching of avoiding blood vessels with intramuscular injections was based on old practices and fears, and that current sites recommended for IM injections, including the deltoid, they actually avoid major blood vessels and nerves. So this is why all these groups here, Department of Health, Centers for Disease Control and Prevention, Public Health Agency of Canada, they all do not recommend aspirating when the intramuscular injection is given in these sites. There's simply no need. Let's look at the methods. You can see that they tell you how they searched so that their search is replicable by other researchers. This is good. In the results, you can see almost no one adhered to the appropriate aspiration method of aspirating for the recommended 5 to 10 seconds. The finding of blood in the aspirate is also managed inconsistently by different nurses. They found that aspiration, being slower, is much more painful than the more pragmatic method of not aspirating. They also found that the nurses studied were simply doing what they were taught based on fear, not evidence. This point was reinforced in the discussion section. Quote, "This review revealed that the decision to aspirate was strongly influenced by what respondents had been taught. Using the recommended injection sites significantly reduces the risk of erroneously injecting into a vessel." However, for many nurses, aspiration has become a custom in the intramuscular injection process, and adopting an evidence-based approach to this may be challenging for some, perhaps due to the fear associated with accidentally injecting into a vessel. Now, they did acknowledge the strengths and limitations of this review, which is great, and they stated that despite these limitations, the review does indicate that aspiration is unnecessary when administering intramuscular injections at the recommended sites in infants and in children, and only mentions the importance of aspirating when injecting into a very specific muscle that we do not use for vaccinations anymore. And in conclusion, this review commented that evidence-based guidelines do not advocate for aspiration, and that current guidance negating aspiration during vaccination should be disseminated through regular educational updates. And nurse educators, like John Campbell, must ensure that their knowledge is up to date so that the intramuscular injection procedure that is taught is based on the latest evidence and guidance. Now, the other limitation of this paper is that it still doesn't tell us whether the people who didn't have their vaccines aspirated prior to injection had any worse outcomes or any worse adverse events compared with people who did have aspiration prior to injection. Let's look at this other review paper to see if it tells us the answers we need. So in the introduction, they again define aspiration as the pulling back of the plunger of a syringe for 5 to 10 seconds prior to injecting medicine. They dig deeper into the aspiration debate. Advocates of aspiration contend that it is a technically easy maneuver that is rapidly performed and well tolerated by patients with no increase in costs incurred. However, due to a paucity of available data, there is no evidence that this procedure is essential or truly beneficial. With specific regard to vaccination, there are no studies that have assessed the need for aspiration prior to intramuscular injection of vaccines in relation to vaccine safety. Furthermore, the widespread use of auto-disable AD syringes, most of which are not designed to aspirate, has not been linked to adverse effects due to the elimination of the aspiration procedure prior to injection of vaccines. So there we have our answer. Not aspirating has not been linked to adverse effects. Again, they're very transparent on their methodology, and they looked at different types of articles from all these different sources, including national and international guidelines. They break down their results into different types of injections. So let's specifically look at the results for immunization. Again, it states that at present, the World Health Organization does not recommend aspiration prior to administering a vaccine. Note that although it says here that similar Canadian guidelines continue to recommend aspiration, if we were to click on the reference, this actually takes us to a 2002 recommendation. If we were to actually Google this recommendation in the present day, and I have done that for you here, this is the current Government of Canada guidelines on vaccine administration as of November 2017. And if you type in aspiration into the search menu, you can see that aspiration prior to injection of vaccine is not recommended, as there are no large blood vessels at the recommended immunization sites, and not aspirating before injection has been demonstrated to reduce pain. Let's go back to this study now. And again, we see good evidence that when using syringes that do not allow for aspiration, there is no evidence of reported increases in adverse effects. AD syringes have been used in mass campaigns for intramuscular injections without any reported adverse effects or injury from failure to aspirate. You can see that this conclusion is corroborated by multiple studies. All complications reported in the literature of intra-arterial injection involve penicillin and other medications and not vaccines. Hence, the practice of aspiration during vaccinations is not evidence-based. So we do have evidence that not aspirating does not cause undue harm. Again, that's why the World Health Organization or my local health jurisdiction, Alberta Health Services, does not require aspiration before vaccination. The fifth and final reason for not aspirating is that it's not practical. When you aspirate, that needle needs to stay in your body for 5 seconds. Note that this example of aspiration given by John Campbell in his video is highly oversimplified. No blood vessel in the body is as wide or as easy to aspirate from as this glass jar. Both the review articles I showed you previously in Reason 4 indicate that we need to aspirate for at least 5 seconds if we were to do the aspiration properly. You need to wait the 5 seconds because it often takes that long for blood to go from the blood vessel which you may have hit to the syringe. So let's count it out. I stick this needle in me, I pull back on the plunger. 1, 2, 3, 4, 5. Easy enough for an adult, but what about if you have kids? Well, from my own experience and from the experience of many parents and many physicians, it is almost impossible to have kids sit still for 1 second, let alone 5 seconds. So with kids, half the time I can't even insert the needle into them because of them squirming and refusing the vaccine. There's even a risk of the needle itself damaging more tissue if the child moves their arm while the needle is in it. And because of the potential trauma of this experience, that actually causes a lot of parents to hesitate before giving the children the necessary vaccinations. So in summary, these are the 5 reasons that aspiration is not necessary. First, the aspiration rationale contains misinformation, like cherry-picking of experts, or oversimplifying complex medical topics. Second, medicine isn't dictated by a single mouse study. There are many possible causes of myocarditis as a vaccine side effect. Intravenous injection doesn't explain everything, and certainly not when it's based on a mouse model. Third, vaccination is still beneficial for us, even without aspiration. It saves lives, and it prevents COVID-19 hospitalization. Fourth, it's safe to not aspirate based upon the available scientific evidence. And finally, fifth, aspiration is impractical and often impossible, especially in young children. The unfortunate cumulative effect of these aspiration before injection videos is that it's causing a lot of unnecessary vaccine hesitancy. When we have vaccines that have been proven to be an effective and safe tool to combat the global pandemic, such vaccine hesitancy can cause the pandemic to drag out longer than necessary. YouTube commentators like this guy have shared that they didn't get the vaccine because the vaccine administrator wouldn't aspirate. You can pause the video here to give his comment a thorough read if you like. Many others have shared their observations with me that people are getting deterred from vaccinations because of the fear of the vaccinator not aspirating. It really didn't have to come to this. Hopefully after watching this video, you can better understand why there's no need to worry excessively about whether your vaccinator will aspirate or not. You can always ask them to aspirate and take the extra pain, but if you forget to ask or if they don't aspirate, there is no need to panic, and there is certainly no need to refuse the vaccination. My plea to aspiration advocates is this: please dig into this issue a bit deeper and understand it more fully. There's a reason why aspiration went out of favor when medicine advanced into the 21st century. Instead of oversimplifying your explanations and cherry-picking your expert advisors, please try to understand at least both sides of the issue, especially before making a plea to all world leaders. Thanks for watching my video. If you liked what you saw and learned something new, please give this video a like so that it can be found by more viewers on YouTube. You can also subscribe to my channel so that you can be kept up to date on future videos related to COVID-19 misinformation. Take care, stay safe, and see you in the next video.